to go through in this session. Thank you very much for joining. I am Arne Wolters. I'm the head of the Improvement Analytics Unit at the Health Foundation, and I'm very happy to host a session today, a workshop on understanding the impact of COVID oximetry at home. And I'm luckily not doing this at all, alone at all. I think what's very unique about this particular piece of work is that we have quite a wide collaboration across a number of evaluators. And we've been working together over the last 8 months or so to support the COVID Oximetry at Home program, which is run by NHS England and Improvement. We're also working very closely with NHS Digital, who is providing access to data for us. And this program, which I won't say too much about because Chris will give an introduction later, is evaluated by 3 evaluation teams. You'll hear all 3 teams today. The first evaluation team is a combination of Reset and Brace, and I'm sure they'll do a further introduction. We're then followed by a presentation from the second evaluator, which is the Institute of Global Health and Innovation at Imperial College, and then finally followed by the Improvement Analytics Unit, which is a partnership between the Health Foundation and NHS England. As I said, we'll run through these 3 presentations, and there'll be time at the end to take any questions. If you do have questions, feel free to add those in the chat box during the presentation. I'll try and pick up on those. When we get into the Q&A session, you're also more than welcome to raise your hand and ask your questions verbally. I will keep an eye on the chat throughout, so if you've got any clarifying questions during the presentation and we're running to time, I might sort of ask some speakers to make some clarifications before we move on, but obviously that will depend on the time you've got. So as you see, there's quite a list of speakers to go through today. I think people will largely introduce themselves. I'll quickly come online in between the sessions, but I'm first going to hand off to, I think, Chris Shirley-Johnson from Nuffield Trust, who is joined by Dr. Holly Walton and Dr. Nadia Krellin to talk about the evaluation that's carried out by Reset and Brace. Chris, if you want to share your slides, then we can crack on. Thank you very much.
Okay, can everyone see this?
Yes, thanks.
Great. Okay. So I'll just close the pane over there. Brilliant. Okay, so this is the first of the talks around this evaluation, these evaluations of COVID oximetry at home. Due to some delays in acquiring data, the project hasn't reached the position we were originally expecting by this stage, but we're able to present some initial findings. And what we're going to talk about today is some background to the use of oximetry for COVID patients, an outline of our evaluation, our approach to measuring clinical effectiveness, and some preliminary findings from our analysis of staff and patient experience. This is the team. It's a coming together of both the NIHR rapid evaluation teams, that's Brace and Reset, led by Naomi Fullop from UCL. So what is the service? First, it's some context about the pandemic and its impact and how this fits in. The charts like this are probably very familiar to everyone. I think if you've been looking through the media a lot, looking through the news a lot. This is the numbers of new cases that have been identified each week. As you can see, they reach a peak of about 350,000 in around the new year. There's a smaller peak in November. There was very much less testing going on early on, so the number of COVID cases that actually ran early on in the pandemic is relatively low. And what this only goes up to May, so we're not seeing here the increase that's suddenly happening at the moment. The numbers of hospital admissions, the hospital admissions are on this scale here, not this one, just to give you an idea of the relative sizes. But these follow this pattern. Of course, you've got the big peak in wave 1 and then wave 2, and they lag new cases for about a week. And then numbers of deaths, again, that's this axis here. And again, these lag new cases for about 2 weeks, and you've got this peak again occurring around the new year. So Evaluations are mostly focusing on this second period, although there is some harking back to some wave one with some of the work we're doing. So what is the service that's being evaluated? Well, this is all about providing pulse oximetry to people with COVID so that their blood oxygen saturation levels can be monitored at home. This is a pulse oximeter. In this picture, it sees you put it over, you've probably seen these much more these days. Put this, the device goes over somebody's finger like this, and it measures the blood oxygen saturation levels, which is measured by a percentage, which is shown in this screen here. These have been in use since the 1970s, but they've been found to have a particular value for COVID patients. Early on in the pandemic, it was found that many patients with COVID were being admitted to hospital with a disease at quite an advanced state and very low oxygen saturation levels, often without any obvious shortness of breath. And the idea was really that some of these patients, if they were being monitored with oximeters at home, they could be picked up much earlier because the low oxygen saturation levels would alert them to going into hospital much earlier. And by doing that, you could avoid more intense hospital stays and probably reduce mortality. So then the monitoring would be then taken at home, and it would be monitored by healthcare professionals remotely, and these would be recorded either on a manually. So a person could maybe just ringing the person up and saying, what are your latest readings? Or there could be some tech-enabled approach, which is based around a smartphone app, for example. And there are two ways in which this is being administered. The main ways is for people that most of the evaluations that we're going to talk about today are centered on what's called COVID Oximetry at home. And this involves monitoring patients before any decision's been made to admit them to hospital. So in the community, somebody will test positive for COVID. This is picked up by community primary care services, or it may be picked up in a hospital A&E department if the patient ends up there. They'll be decided whether they're eligible for home monitoring, and if they are, they'll be sent home with a pulse oximeter, and then their readings will be monitored remotely. And that patient may then recover, or if their readings get too low or severe symptoms become too severe, then they would be admitted to hospital. The other approach, which isn't going to be focused on so much today, is what we call virtual wards, and this is actually for this is administered by hospitals themselves. Patient is in hospital, they've had COVID, and it's deemed that they could actually be sent home and they could be monitored at home, even though they may still have COVID. And again, with a pulse oximeter, and they may recover, or they may again, for similar reasons, be escalated and readmitted back to hospital. In both cases, the aim is not to keep people away from hospital, but to ensure people are treated at the right place and at the right time, and thus optimize the use of hospital resources. So, because it's not a way of saying avoiding admission, it's really about saying if a patient needs hospital care, they will still be admitted, but it's about treating people in the right place. So these services now operate in all CCGs, and most of the acute trusts have got virtual wards. This chart shows this is the number of new cases each week here in the green, and these just showing the number of services that there are that have opened up over time since September up till February. And you can see most of these have been opening up either during or just after the second wave. Some of these existed right back in the first wave. This blue dotted line shows we're really not quite sure when some of the oximetry at home services exactly opened, so the data wasn't collected until mid-November. But we do know there are some of these that existed opened right back in April or March or April last year. Okay, so I'll now pass over to Holly Walton, who will provide an overview of our study.
Thank you, Chris, and apologies, my internet just dropped, so I'm hoping it stays on for the presentation. So I just wanted to give a bit of a question. Is COVID care at home associated with mortality and use of hospital services? The second is on cost effectiveness. So what are the costs of COVID care at home, and is it good value for money? The third is on patient experience, and we're focusing on the experiences and behaviours of patients receiving COVID care at home, variations and impacts on inequalities. And the final work stream is on staff experience and implementation, and we're exploring the factors influencing delivery and implementation of COVID care at home, variations, and staff experiences and impacts on inequalities. So today we'll focus on introducing our plans for workstream 1 and initial findings for workstreams 3 and 4. Next slide, please, Chris. So this work built on our phase 1 study of remote home monitoring during the first wave of the pandemic. And phase 1 consisted of a rapid review and an evaluation, including staff interviews and a cost analysis in 8 case study sites. More information can be found in the publications on the slide, and I'm now going to hand back over to Chris to talk about the first work stream, clinical effectiveness.
Thanks, Holly. So the approach to clinical effectiveness, this analysis is yet to be completed because there's still data that hasn't arrived yet. But the idea is basically this is complementing the other evaluation teams who you'll be hearing from later today. Our approach is to focus on the hospital or CCG level, mostly using aggregated data or other data that we could readily get hold of. And alongside the direct evaluation, it's also to see how well such data can be used in this way, and which may have implications for longer term routine monitoring. This shows our plans, just basically outline of the plans for oximetry, for modelling oximetry at home. The main outcomes here are mortality and hospital admissions, and there'll be various relationships, of course, with the numbers of new cases, factors like age. But the important things are around the uptake of these services and the influences that these will have on outcomes. For example, so we've got the uptake of the oximetry at home services within a CCG, and further influence of whether tech-enabled services actually provide additional benefits. For the virtual wards, our analysis is going to focus on individual patient level data. These outcomes here, the main outcomes here will be readmissions and bed days, relating these to patient characteristics, hospital factors, etc. And the main thing here again is around whether or not the existence of a virtual ward has an influence on these outcomes. The approaches like this comes with a lot of challenges. There's a whole load of possible caveats for this, and here's just very few of them. With oximetry at home, with aggregated data, aware that any true impact may be diluted, particularly if uptake rates are quite low. Data on uptake isn't complete for all CCGs. When I put this slide together, there were only 38 CCGs where the data was complete. Probably a few more now, but again, it's not much. It's around 40 at the moment. And these CCGs are not evenly distributed over the country. So, for example, there may be quite a few, for example, in the southeast and the northwest, but not so many over in the east of England. For virtual wards, we're not going to be able to link HES to data on who is actually discharged to a virtual ward from each hospital. HES is what we'll be using mainly for this analysis. And under both cases, we need to take account of other influences, some of which we'd be able to get information on, for example, around vaccinations, but some which would be harder. For example, the fact that new treatments are always being developed over the course of the pandemic, which are affecting outcomes, often in a positive way, and there are other coexisting trials exist that are running alongside as well. Okay, I'm going to pass back to Holly, who is now going to talk about the staff and patient experience.
Thank you, Chris. So now we're going to turn our attention to implementation, staff and patient experience and some of our early findings. Next slide, please, Chris. So to find out about staff experiences and implementation, we have collected data from staff involved in delivering COVID care at home, including 292 responses from our staff survey in 26 COVID care at home services. We also included 58 interviews with staff delivering the service from 16 services, and this included clinical leads, those delivering the service, and those involved in data collection and use. We also conducted 5 interviews with national leads. In order to explore patient experiences, we've also collected data from patients and carers who have received COVID care at home, including receiving 1,027 surveys from our patient survey in 25 COVID care at home services. And we also conducted 62 interviews with patients and carers in 17 services. And this analysis draws on 956 survey responses, which have been analysed so far. So I'm now going to hand over to Nadia to talk about some early implementation and staff experience findings.
Thanks, Holly. So just thinking about the typology of the services, we categorised the 26 services according to 4 domains, these being type of model. So Chris outlined earlier provided an overview of the different models. So we included 9 COVID Oximetry home services, 4 virtual wards, and 13 were a combination of both. Then thinking about who leads the service. So most of our services were led by primary community care, and some were also led by secondary care, and then some were led by secondary care only. And then for type of monitoring, we had most of our services were led by where the monitoring was digital, a combination of digital and analog. So digital options included using a digital app, also automated text messages, emails, and also automated phone calls. And 7 of the services were analog only. So these were paper-based, using a paper-based diary, and also phone calls with staff. Thinking about the entry criteria for the services, so the age criterion varied across the services. So for some it was the age criterion was 18 years, for some it was 50 years, and the virtual wards didn't use an age criterion. For the there was also 23 services that used risk factors as criteria. So these included things like clinical vulnerability, high BMI, severe mental illness. So this slide just provides an overview of the services. Next slide, please, Chris. So thinking about staff experiences of delivering the service. So on the whole, staff had a very positive and rewarding experience of delivering the service. 3/4 of staff reported that it impacted positively or very positively on their job satisfaction. And most staff felt confident in carrying out their responsibilities. So 92% of staff reported this, and 88% of staff in the survey reported that that they have felt well supported in their role in delivering the service. Some challenges were noted by staff, and these related to workforce availability. So thinking about staff isolating or shielding, and also managing the demands of the pandemic, so the peaks and troughs, and scaling up and scaling down the service. Staff felt that patients had engaged well with the service on the whole. However, some patient groups did face barriers to accessing the service. So, for example, those who English wasn't their first language, for those who had a visual or hearing impairment, for those who had a learning disability, or perhaps didn't have digital access. And some staff felt some patients were less likely to engage with the service. So for example, younger patients who perhaps were still working, and many staff, half of staff reported tailoring the services to accommodate service user needs. or requirements. For example, changing the method of monitoring, whether it's via phone or text, sending out reminders, the frequency of monitoring, whether it was once a day or twice a day, whether it was also translation of information and translation services involving family members or friends in the service. So those are just a few examples of the way it was tailored. And I'm going to hand back over to Holly to talk about the patient experiences.
Thank you, Nadia. So I'm just going to outline some early findings from our patient experience study. So we found that patients mostly held positive views about the service. For example, 92% of survey participants rated the service as good or excellent, 90% felt reassured, and 88% found it helpful when dealing with their symptoms. These findings were supported by our patient interview findings, which found that most participants felt that the service was reassuring and that it was appropriate to be cared for at home. Participants spoke very positively about the staff delivering COVID care at home. However, a few participants did speak about some negative views of the service, for example, gaps in the provision of the service or receiving too many calls. In terms of engagement, we found that participants generally found it easy or very easy to engage with the service. Survey findings on ease were supported by interview findings, and this diagram breaks the findings down into different behaviours involved in the service. So many participants found it easy to understand the information they were given. However, a few participants did report some issues or the need for further information. In terms of monitoring using the pulse oximeter, 98% of survey respondents found it easy or very easy to use. Interview findings supported this, but found that some people did find monitoring difficult due to other health conditions, or that monitoring made them feel worried. In terms of recording readings and providing readings using the diary and telephone or digital options, 96% found it easy to record and 97% found it easy to provide readings. Some participants did speak about wanting more support or found recording burdensome. Finally, in terms of escalating care when needed, 86% found it easy to seek further support. However, our interview findings found that a barrier to escalating care was that some participants did not want to go to hospital or seek further support when advised to. As part of our evaluation, we identified many barriers and facilitators to patient engagement, and our findings showed that a key facilitator to engaging with the service was support from family members, friends, and staff involved in delivering the service. A key barrier was knowledge. Next slide, please, Chris. So before we finish, I just wanted to give a few examples of the emerging lessons from our evaluation, but these are not exhaustive. So one example of a key lesson is the need to develop training manuals and instructions for staff and patient information materials. A second example is that there needs to be close relationships developed between all of those involved with clear and regular lines of communication. And I'm just going to hand over to Nadia to talk about next steps before we finish.
Thanks, Holly. So this slide just provides an overview of what we're going to do next. So we'll be doing subgroup analyses on the survey and interview data. So thinking about comparing the analog models versus the digital models, thinking about the differences between the COVID Oximetry at home versus the virtual wards, and thinking about inequalities to access. As Chris mentioned earlier, we'll be doing some work around clinical effectiveness and also cost effectiveness. And also we'll be triangulating the data across the 4 work streams to give a mixed methods view of the service, working with our evaluation partners to triangulate the findings. And we'll be thinking about how the service translates for other conditions. Thank you.
Great. Thank you very much, Chris, Nadia and Holly. There's a couple of questions already that have come in and some responses coming in from other people in the workshop. Please do keep sending your questions in so we can have a discussion at the end, and certainly the questions raised here, which I think hints on health inequality, is something I'm also keen to touch on in the Q&A if we can. Before we get there, though, first going to hand over to Dr. Thomas Beanie, who will be presenting on behalf of the second evaluators, so the second team rather, so from Imperial College, the Institute of Global Health and Innovation. Thomas, do you want to share your slides?
Will do. Thank you, Arne. So hopefully you can see that. So my name is Tom Beanie. I'm a GP and a clinical research fellow at Imperial, and presenting on behalf of our team today. Unfortunately, Dr. Jonathan Clark, who's due to be presenting, couldn't make it today, so it'll just be me from our team. Now, as Chris already mentioned, there were some delays in terms of us getting the data, so we're not presenting as many results as we were expecting at this stage, but we're going to focus on our evaluation methodology and how that's developed as a result of the data we've had in, and present some of the preliminary results that we have got. So as an overview of what we aim to do, we have three work packages. I won't go into this in detail, but just to cover it briefly, the first work package is trying to identify inequalities in access to the Oximetry at Home programme. So who is accessing it and who is not. The second is trying to understand the impact of the programme in terms of mortality and secondary care utilisation. And our final work package is then trying to explore variation between oximetry at home sites where there is enough data. And that's variation both in terms of who's being onboarded onto the programme and in terms of outcomes as well. But the one we're going to focus on today is the second work package in terms of quantifying the impact of the programme. Now, you heard from Nadia earlier about the entry criteria for oximetry at home. And this is a screenshot taken from the NHS England standard operating procedure for the programme. And the idea is that people enter the programme if they have been diagnosed with COVID, that's from either clinically or based on a positive test, they're symptomatic, and they're either age 65 or older or under 65, but with a condition that puts them at risk. And originally, this was limited to people who were listed as being clinically extremely vulnerable, but this area that's been highlighted in yellow shows that it's now become much broader. So the idea is that where there's any clinical judgment that suggests someone should be on the programme, then they are onboarded as well. So it really is very broad. And as Nadia mentioned earlier, in some sites, people over the age of 18 are being onboarded, and others it's over the age of 50. And that has implications for our evaluation, as we'll see. Now, the key outcome measures we're looking at are mortality and healthcare utilisation. So mortality measured by death within 28 days of the positive test, death due to COVID anywhere on the death certificate, or as the direct cause of death. And healthcare utilisation is looking at A&E presentations, emergency admissions to hospital, and also intensive care admissions. We have a real wealth of data here. We've got the on and offboarding data for all those onboarded or offboarded from the Oximetry at Home programme. So that's about 22,000 patients so far, although we're expecting an update to that. And of those onboarded, about half have oxygen saturations. We also have 2.5 million people with positive COVID tests from the 1st of October 2020. And this is linked to primary care, secondary care, and mortality data. Now, to give an overview of the process from test to onboarding to then offboarding. So on average, the median duration from someone having a positive test is 4 days. So 4 days to onboarding. But in some cases, they're onboarded and their test is a few days later, but on average 4 days. And then people tend to stay on the programme for 11 days. And you can see on this histogram on the right, there's a real spike there at 14 days. And that's because at 14 days, most of the protocols state that people should be contacted. And if they're well, they can then be offboarded from the programme and then return their pulse oximeter. So that's why we see this spike at 14 days. But some are on the programme for much longer. So 1% are on the programme for 36 days or longer. Now, when it comes to trying to analyse the impact of the programme, there's a problem if we're looking at this at the individual level. And there are three key confounders here. One, which Chris mentioned earlier, is that we don't have complete data for all CCGs, and about 40 CCGs have complete data and the others are only partial, which would mean that there may be some patients who were onboarded that we just don't know about. The other issue is over confounding. So certain factors are associated with your risk of being onboarded, but also your risk of a negative outcome from COVID. Now, many of these are measured, and we have in the data things like age, sex, ethnicity, deprivation, comorbidities, strongly linked to mortality or risk of admission, but we can adjust for those. But the real issue is those confounders that we can't adjust for, and that is disease severity. So as an example here, this is a scenario where we've got 3 different patients, Mr. A, Mr. B, and Mr. C, and they all have identical backgrounds and underlying risk of COVID. And they all develop the same symptoms on the same day, they have a test on the same day, and their result comes back on the same day. Now, Mr. A improves, no further action needed. Mr. B deteriorates, worsening cough, shortness of breath, calls up his GP, who refers him to the local COVID hub. His saturations are found to be 95%, which is acceptable, doesn't necessarily need admission, and they are then onboarded onto the programme. Compare that to Mr. C, sorry, the text maybe doesn't come out all that well here. Mr. C has oxygen saturations of 92, which would warrant admission to hospital, so is therefore admitted and not onboarded onto the programme. But in terms of us trying to identify who is a suitable control here for Mr. B, it's difficult to pick up, should that be Mr. A or Mr. C, and one is much more well, one is much more unwell. So analysing this at the individual level is potentially problematic. So our original intention was to use a stepped wedge design. And this is a method that is a form of cluster randomized design that's been used in clinical trials and a relatively new method of analysis. And you can see the various different methods of designing a cluster randomized trial on the right here. And the key about a stepped wedge design is that you have for every site, so these would be the oximetry sites, you have both pre and post implementation time periods that you're measuring over. And you can also modify this. So this one on the bottom right, you can modify this to include a transition period where none of the measurements count. So these are during the implementation of a program. Often things are not up and running properly, so you want to discard the information during that time period. Now, the advantages of this sort of approach are that it's population level, and we get around those individual level factors. We do get observations before and after in every site, and therefore we can account for changes over time, and also how some sites may differ in the baseline mortality or risk of admission. Now, of course, in a trial setting, this would be randomized, and this is not randomized here. And you may suspect that those sites enrolling early perhaps have better outcomes than those enrolling later, and that could be possible. Also, geographical boundaries are not constrained. Some sites, there may be some blurring. Someone might live in a particular area, but get enrolled in a program in another. We may see interdependencies as well between sites. So one site might cover for a wider area to begin with, but then as new sites open, that changes. And the key disadvantage here is the uptake of the eligible population. So this table here summarizes the totals within each of these different risk groups, the totals actually onboarded onto the program between the 1st of October and the 31st of March. And you can see that even in the highest group, which is the 65 to 79 year age group, who are clinically extremely vulnerable, only 2.9% over that 6-month period are onboarded onto the program. So all of those in theory should be eligible. Now, that of course varies over time. Not all sites were up and running on the 1st of October. And here we can see how those different risk categories vary over time. And the majority are being, in terms of totals onboarded, are being onboarded in January and February, as we might expect with the peak of the pandemic. But actually the rates, so the proportion of all those eligible who are being onboarded, doesn't really peak until April, where we actually have quite low numbers. So this presents us with a bit of a problem, because even at that peak time of being onboarded, only about 2 to 4% of these eligible risk groups are being onboarded. That varies as well between CCGs. So these figures demonstrate the trajectories for each CCG. And really it's just to highlight that there is variation. And actually in this figure on the bottom right, the majority of CCGs are below that 10% threshold. So fewer than 10% of all positive tests being onboarded. Now there are a few that are onboarding between 10 and 40%, but probably only totaling about 10 CCGs in total, which isn't going to then give us a national level picture. and 27% of all CCGs make up just over 3/4 of all onboarded patients. So we really would need to modify this stepwise approach. So we're going to include an implementation period where we discard measurements until a site reaches a particular threshold. But we want to try and do this nationally if we can, because the idea of our evaluation is to look at the impact of the programme nationally. But we may then do subgroup analyses where we focus on particular time periods with high numbers and proportions onboarded. So that leads us back then to thinking, well, should we try and do a level of individual patient analysis? And we've considered how we might be able to create as uniform as we could get group of patients. So what we intend to do is select all those patients who have had either a primary care or an A&E attendance within 2 or 3 days of their test. And of these, there will be 3 possible outcomes. They'll be onboarded within a day, they won't be onboarded at all, or they will be admitted. Now, anyone admitted we will exclude on the basis that they have severe COVID that requires admission. But then what we end up with is a group of cases and controls where they have all had a clinical assessment within 2 to 3 days of their positive test. And we can say that none of these individuals at that point of assessment needed admission. So they should be relatively uniform. And what we then do is we match them. So we'll have a case control matching, which will be through coarse and exact matching or propensity score matching. We've not quite decided on the approach we'll use at this stage. And then we will look at mortality and utilization from 28 days of that first attendance to primary care or A&E, with the proviso that we'll be excluding anyone admitted within that first day. And of course, we'll need to look at different subgroups in terms of those attending primary care versus A&E, because those will be very different population groups. So to summarize, we've gone from just looking at the step wedge design, which we think we should use, but there's a fear that if there is any effect of the program, it may well be diluted by the fact that there is low uptake. So we do need to look at other ways of evaluating as well. So that's certain subgroups of our step wedge design, but also this individual level analysis that I've described. So these are the 2 different approaches that we will be taking. Now, very briefly in the last couple of minutes to talk through some of the preliminary findings. Now, these are the characteristics of those onboarded. So of all patients onboarded between October and the end of March, just over 3/4 have a positive test, and about 2/3 of those had 2/3 had symptoms at the time of the test. So high proportions who actually had no positive test or had no symptoms at the time of testing. Now, that presumably changes over time. Someone may have no symptoms when they test, but then subsequently develop them. Now, in terms of oxygen saturations, there's quite a range, but the vast majority of those that are recorded are between 95 and 100% range, as we would expect from the program, given that lower thresholds would probably warrant admission. There's a wide range of demographics here. We'll see on the next slide how that compares to those not onboarded. Tendency for more women to be onboarded than men, and a higher proportion of people of white ethnicity compared to others. Here we can see how the age profile varies in those onboarded compared to those not onboarded, and there are higher proportions of older patients onboarded compared to those with positive tests who were not onboarded. As we would expect, this is picking up higher proportions of older patients. And finally, looking at deprivation, more people are being onboarded from the most deprived deciles. Now, of course, what we don't know is whether this just reflects the underlying incidence of COVID, or whether this is that certain groups are more likely to be onboarded. And that's a key part of our evaluation to work that out. But that requires us to know exactly who that underlying population is first, which we've not got to that stage just yet. About a fifth are clinically extremely vulnerable, and about 2% were care home residents, and 2% of all those onboarded died from any cause within 28 days of their onboarding. So those are just a few of our preliminary results, which over the next couple of months we will be adding to. So thank you very much, and I'll hand back over to Arne.
Thank you very much, Tom. Very interesting, and I think some of the concepts you just explained will also feature in our next presentation by the Improved Analytics unit. So let me just put up the slides before we crack on. I hope everybody can see that now. Yeah, so the third presentation is by the Improved Analytics unit, and some of you might have been expecting Therese Lloyd to be here and join us in the presentation. Unfortunately, she can't make it, so I'm going to cover the first couple of slides from our team before I hand over to Dr. Stefano Conti to talk about some of her work as well. Very briefly, for people who are not familiar with the Improvement Analytics unit, we're a partnership between the Health Foundation and NHS England and NHS Improvement, and we in particular focus on evaluating complex changes in local initiatives and to sort of inform national policy making and support learning and improvement. And I guess sort of what we specialize in, if you like, is the use of counterfactual analyses, and this touches on some of the aspects that Tom has already talked about. So when we're either evaluating, well, I think if you think about medication, people are very used to the concept of a randomized controlled trial, where people sign up for the trial, they're randomly assigned either to be the intervention or the control group, and because that allocation is random, you expect there to be no difference between the two groups. And when you're designing a novel health services and you want to evaluate the impact that's having, a randomized control trial can be really tricky, and you can imagine in some cases also quite unethical. And that's really where observational studies come in and can offer a practical alternative. The key aspect really of a counterfactual study is that we have an intervention group and a control group that are, as far as we know, as similar as possible. And in particular, we want to control for any observed differences between the groups, but obviously we need to be aware of any unobserved differences as well. And as you've seen from the slides that Tom presented, that's a particular challenge here, looking at an individual level analysis. So when we set out and designed our study designs, we were trying to create an individual level study design as well as a sort of population level one to sort of try and pick up the overall impact on the program as well. But the challenges that Tom mentioned in terms of a relatively low uptake and maybe not as clear a definition of the eligible population, if you like, because there's different ways that the program has been implemented locally. Some of our original designs didn't quite work, but we're going to try and talk you through those. And I'll start talking about our regression discontinuity design, and then I'll hand over to Stefano, as I mentioned before, on the generalized synthetic control analysis. So regression discontinuity design is trying to identify a discontinuity in the data that is closely linked to the eligibility of the program, but without likely to be impacting the outcome. And I'll show a slide in a minute to sort of demonstrate where we found that. But in particular here, because the standard operating procedures that Tom showed, the assumption was when the program started, it wasn't implemented yet, is that if you test positive and you're aged over 65, you're eligible. Now, if you're, and that's assuming you're not clinically extremely vulnerable as well, but then if you're under 65, you wouldn't be eligible. So we were thinking that discontinuity at the age of 65 might prove very helpful in having two populations that are actually very similar, where one is eligible and the other is not. But we wouldn't expect there to be much differences between somebody aged, who's just turned 65 versus somebody who might be 63 or 64. And we've used this approach in a previous study. So the slide I'm showing here was when we evaluated the named accountable GP policy, which was introduced about a decade ago, where if you were aged 65, you'd get a named accountable GP. But obviously you're not very different from somebody aged 74. And what you can see here, and on this graph, you see the assignment, if you like, so what percentage of patients has a named accountable GP, and we see a very clear jump, and that jump allowed us to sort of evaluate that difference. So we're hoping to find something very similar in what I call the uptake, or what Tom referred to as the onboarding of patients. So this is the percentage of patients onboarded out of all those that test positive, so out of that eligible population, around the cutoff of 65. And what we were really hoping is that we would see a relatively low uptake under 65, and a high uptake over 65, whereas in practice, really, there's only a couple of percentage point difference between the two. And unfortunately, the method sort of assumes that if you're over the cutoff, you receive the treatment. If you're under the cutoff, you don't. And there's a little bit of wiggle room there, but we don't quite have the discontinuity here that we'd hoped. And the overall uptake is also relatively low, so the number of patients that would be included in the analysis as a result would be quite low as well. So unfortunately, we had to conclude that for this particular design, we don't think it would give sort of reliable results, so we've decided not to go ahead with that. And we will sort of write up the feasibility study and be transparent about how we got to that decision. But that's not something I want to dwell on for now. So what I'll do is I'll quickly hand you over to Dr. Stefano Conti, who will talk about our approach at a population level using generalized synthetic controls. And he'll tell you that he's had to make some adjustments to our study design as well as a result of the data that we found, but we think there is still a study there. So Stefano, let me know when you want me to move on to the next slide. Thanks.
Thank you very much, Arne. By all means, you go ahead. I take it everybody can hear me, and good afternoon to the audience, and thank you for your interest in the COVID Oximetry at Home program and evaluation. As Arne mentioned, we do set out with asking ourselves an evaluation question we intend to address. And for this particular strand of the evaluation as conducted by the EU, it has to do with determining, quantifying the impact on hospital activity that has been noted during the second wave of the pandemic, so specifically from, say, September 2020 onwards. That has been noted, like I said, at CCG level in England, so this is going to be our sampling unit or unit evaluation, between CCGs offering a COVID Oximetry at Home pathway to their eligible population against those not yet, because eventually the program will be available across the whole of the country, offering any at all. So this study design, as we intended it, and by we I mean chiefly my collaborators, Paris in particular, but also Arne and Therese Lloyd and Will Parry, who contributed to this presentation, is that per the PICO you see outlined in the remainder of the slide, we set out to identify as the target population individuals who are registered with a GP in England, a GP practice in England, and have tested positive to COVID-19. Fulfilling these two conditions, they have to be either of age 65 years or over, or have to be listed or classed as clinically extremely vulnerable, either one or the other. The intervention, as we intended into this particular approach to evaluation, consists in our sampling units, again, the CCGs, delivering to the eligible patient population a COVID Oximetry at Home clinical pathway. The comparator or comparators for our evaluation are essentially made up of CCGs in England that essentially do not offer a COVID Oximetry at Home pathway. So once again, the contrast within evaluation stands between CCGs offering or not offering a COVID Oximetry at Home clinical pathway. As to the outcomes we are looking into, and that exhausts the PICO process, we are looking into rates for a number of secondary care - hospital activity metrics as measured within 28 days of individuals first testing positive to COVID-19. And these are, as customarily is the case, accident and emergency attendances, emergency admissions, critical care admissions for more severe cases, rates of mortality, and last but not the least, length of hospital stay as measured in hospital bed days. Please have the next slide. Thank you very much. So Here comes the first of our challenges ahead. As it's been mentioned before, we received the data relatively late, and that forced us to quickly look into some, of course, exploratory statistics. And this is where a few surprises came up. What you see here is a bar plot whereby on the x-axis over time, you observe week dates covering pretty much most of the second wave period in 2020. On the y-axis, you observe what I define being the onboarding fraction or rate. In other words, that's the proportion of individuals who've been onboarded onto a COVID Oximetry at home pathway out of the eligible population, essentially, well, eligible people testing positive to COVID-19. The height of these bar plots indicates the onboarding fraction across the country. So this is not a bar plot organized by CCG, it's for the whole of England. The bar plots that are depicted in green indicate the 6 weeks time period starting with October the 19th, whereby we originally set out to produce our evaluation, so our study follow-up period. Numbers sitting on top of each bar indicate absolute numbers, frequencies of individuals at that week being onboarded onto CO@H. The total number during the so-called green period, the follow-up period, stands at lower than 700, and that basically in the end, the onboarding fraction is lower than 0.2% in most cases, not 2%, 0.2%. And that basically takes away any hope that we will be able to run an evaluation as outlined in the PICO I presented to you earlier. Of course, one might think that by pulling the evaluation period forward, we might be able to garner a higher onboarding fraction. That is a reasonable expectation, except that if we were to do that, we would be finding ourselves with fewer, in fact, hardly any CCGs not offering us COVID Oximetry at home pathway, thereby depleting the pool of potential controls for our evaluation. Next slide, please, Arne. As such, we are in between a rock and a hard place, as some would say. Evidently, it appears that we are unable to carry out the evaluation as we originally intended to, per the statistical analysis plan we provided. So we had to think of a plan B, and that, as it stands, consists of basically contrasting not CCGs offering versus not offering a COVID Oximetry at home pathway, but rather CCGs exhibiting a high onboarding rate against CCGs whereby producing a low onboarding rate. This appears to be a more viable evaluation for a number of reasons. First of all, it will allow us to look into what actually happens in 2021. So during the full period of the second wave of the pandemic. Of course, it raises the natural question, which we are currently exploring, as to determining what is it meant by a CCG with a high onboarding rate or high onboarder, or a CCG with a low onboarding rate. Thresholds are being explored. We're in the process of determining them, and we will surely be subjecting them to a number of sensitivity analysis. There will be, at any rate, suggested by the data. I've already outlined below, already mentioned what the revised evaluation question will be looking like. So now we are effectively contrasting hospital activity indicators between CCGs showing a high onboarding rate versus CCGs showing a low onboarding rate. Next slide, please. Thank you very much. The analytical approach we chose in order to perform this evaluation is called the generalized synthetic control. It's been published a couple of years ago on policy analysis, and it's been since used rather extensively, for having been around not too long, in a number of case studies ranging from econometrics to healthcare policy. It's also been used quite successfully, I should mention, in the improvement analytics unit before. It's a method that we chose because we believe it's well suited to tackle aggregate level, in our case CCG level data, with a clear administrative or geographical limitation, delimitation, I mean. It provides an estimate of what Arne has described before as the counterfactual, that is the outcome expected by high onboarding CCGs in a low onboarding scenario, through fitting a carefully selected regression model. This model essentially provides, like I said, an estimate of the counterfactual, which conveniently comes equipped with an indication of the uncertainty of the estimate, meaning essentially standard deviations or confidence intervals. Very quickly to the next slide, please, just to offer a graphical display of what the generalized synthetic control approach produces in a different case study that has been looked at in the improvement analytics unit. This is just an example. On the y-axis, you will see time, measured in this case in months. On the y-axis, the rate of emergency admission per 10,000 people from a given CCG-specific location in Britain, in England, I mean. The blue line can be compared to what would be the counterfactual estimated, in our case, for low onboarders by the generalized synthetic control method, and the red line would instead present observations from high onboarders, from high onboarding CCGs. At any given vertical line, the difference between the red and the blue line corresponding to that X ordinate in time will provide a measure of the effect of the impact of what we hope to be finding from the COVID Oximetry at home. This concludes my presentation. Many thanks, Arne, for helping out with this slide flicking. And of course, many thanks on behalf of the AU and of my colleagues presenting from Imperial College and earlier. Arne, back to you.
Thank you very much, Stefano. Yeah, and thanks to all other speakers as well for their presentations. There've been a couple of questions raised in the chat that have also been answered there already, but I think there was one in particular that I thought was really helpful to look at, which was raised by Ganesh quite early on, talking about the effectiveness of pulse oximeters on varying skin color, and Naomi very helpfully posted a link to an article where that was addressed already. But I think it speaks to sort of health inequalities, and I was wondering if I could ask maybe both Holly or Nadia and Tom as well, to think sort of if they could explain how they might account for health inequality in the analysis that you're planning on doing.
Definitely. So I'm going to let Nadia take that one, if that's okay, Nadia.
Sure, thanks.
Yeah. So in the survey work and the interviews, inequalities to access is something that we will be certainly focusing on from a staff and patient perspective. So thinking about the barriers to access. So around, as I mentioned earlier, around language. So people who are non-English speaking first language, around issues such as digital access, around other issues around tailoring the service as well. I don't, Holly, if you want to come in.
Yeah, the other thing to say is we've collected a lot of demographic information for both the survey and interviews as well. So we're hoping to run some sub-analyses comparing patient experience and staff experience across the different ethnicities, across different age groups, to see if we can explore some of those barriers and facilitators in more detail. Ganesh, hope that answers your question.
And shall I jump in now? So thanks, Ganesh, because that is a really key part of our evaluation. So the first work package is focused solely on looking at inequalities in who is accessing the service, and particularly trying to understand how that varies across sites as well. The question about pulse oximetry, I mean, we know that in people with dark skin, often the saturations can be falsely reassuring compared to the actual underlying arterial oxygen levels when someone then has those checked. Whether we have enough data here to actually look into that, I don't know. I mean, we've not set up to specifically answer that question, but certainly something we plan to do is look at the different thresholds of oxygen saturations that people are onboarded with, and see how that varies according to different groups. And we'll be looking at outcomes by oxygen levels, but whether we can also look at ethnicity within that as well, I doubt we'll have the numbers to look at that directly. But certainly trying to understand the overall inequalities in the service is a key part of what we're doing.
Thank you very much. Ganesh, did you want to come in?
Yes, but it's just to say, I know it's quite a big thing in India, because I know a lot of these home kits, they were sent out in India, and there were a lot of questions about how useful they were for the Indian population, which is obviously huge. And I suppose it goes to the wider question of how often healthcare is based on the assumption of what is the norm, which is often sort of somebody of white skin or Western background, when actually the world's population is not like that, and UK's population is not like that, and London's population is not like that. So it's trying to build this type of thing in. So all the time when we're asking these questions, we're thinking, how does it impact on different people? And particularly with COVID, because when we look at the different rates of death, both in staff and in the community, it's far higher in Black and minority ethnic groups. So it's just keeping that really at the forefront of people's minds, I suppose.
No, absolutely. And thank you very much for asking that question. And I think certainly, talking to other evaluators as well, I think sort of health inequalities is a big challenge to the NHS, and I think it's something we want to incorporate in pretty much all the work we do, certainly where the data allows that. And I think if anything, it's probably a shout out to improve data access around some of health inequalities as well, to make it easier to routinely be able to pick up these things. So thanks very much for asking that question. I'm sort of conscious of time, and I haven't seen any sort of new questions come in the chat that haven't been answered already. So I think what I'd like to do is just thank all the speakers that you've heard today. So Chris, Tom, Holly, Nadia, and Stefano as well. And I hope you're okay if I say this, that I think we'd all be happy to be contacted if you've any follow-up questions as well. The various study protocols that have been presented to you today are also available online if you would like to find out more. So please feel free to get in touch with us at any point. And we would have liked to be further along the evaluation and share some further findings, but I'm sure we will reach out to you again and share those when we can. So thanks very much for joining us this morning, and hope you enjoy the rest of the conference as well. Thank you very much.